Ma'am, we can start talking after 30 seconds, right?
We are already live, right?
Now it is live. Now it is live, yes.
Yeah. We'll start.
Yes, ma'am.
Yeah. So good evening, everyone. I, Dr. Pramila, on behalf of the Indian Thyroid Society, welcome all of you to this new edition of the Thyroid Clinics. We already had an immense success of our Thyroid Clinics in the last year, and now we have come back again with some changes. And today we are doing the first of the Thyroid Clinics. So in this clinic, we will be having a lecture and a talk. We will be having a case discussion, and we'll also be having a very interesting quiz for the students. So kindly be there online, and the links and everything will be displayed soon, how to join for the quiz. So we have started this new edition of the Thyroid Clinics under our new president, Dr. Krishna Sheshadri. And we hope that all of you will get some benefit regarding thyroid disorders by attending these clinics. And these clinics will be held every second Wednesday of every month. So I hand it over to Dr. Ganvi, who will be taking over the proceedings from here.
Thank you, madam, for the introduction. So, as we know, we are grateful to have you all here today for this enriching session on thyroid health. Yeah, as I said, we are definitely grateful to have all of you here today for this enriching session on thyroid health. The thyroid clinics are being currently led by our esteemed coordinators, Dr. Pramila Kalra Madam and Roma Pradhan Madam. Their leadership and dedication continue to guide us towards excellence in patient care and education. We are also joined by our distinguished colleagues, Dr. Krishna Sheshadri sir, who is the president of ITS, Dr. Arun Menon sir, who is the secretary, and Dr. Mini madam, who is the treasurer. Together, they have been helpful in guiding the work and initiatives of ITS. We are fortunate to have Dr. Chitra Madam, Dr. Vijay Reddy sir, as part of this vibrant team that worked tirelessly to bring you the latest insights in thyroid care. So to start off, we will have a case presentation by Dr. Krishna Reddy, who is the senior resident from AJ Institute of Medical Sciences. We are also honored to have our distinguished guests, Dr. Ganesh HK sir and Dr. Sahana Madam, who will be moderating the session and guiding the discussion. This will be followed by a very thought-provoking talk on the topic, should asymptomatic retrosternal goiter be referred for surgery, by Dr. Amit Agarwal sir. This is a topic that raises many questions, and Dr. Agarwal sir's expert insight will shed light on this often debated issue. And of course, we will conclude the session with the quiz conducted by one of the leading endocrinologists, Dr. Neelakshi Madam. This will be a fun and engaging way to wrap up this session, and we encourage all the participants to join. So the quiz is scheduled for 8:45 p.m. and to participate, simply click on the Attend Now button on the live streaming session hosted on Slido. So I would like to invite now Dr. Vijay sir to introduce our guest speakers, our moderators, Dr. Ganesh sir and Dr. Sahana Madam, as well as Dr. Krishna Reddy for the case presentation. I now hand it over to Dr. Vijay Reddy sir.
Thank you, Dr. Ganavi. Welcome to the Thyroid Clinics from the Indian Thyroid Society. So the first case we have is case presentation by Dr. Y. Krishna Reddy. He is a second year PG from Department of Endocrinology, AGMS, Mangalore. And he'll be presenting a interesting case on the topic of not innocent until proven otherwise. So this is like a court case. So in court, we have to prove ourselves, and we have to prove that we are innocent until proven otherwise. So similarly, he's also got a good case to defend. So not innocent until proven otherwise. And to moderate the session, we have two eminent academic endocrinologists, Dr. Ganesh HK, who's Professor and Head, Department of Endocrinology, AGMS, Mangalore. And he is He's won the AR State Award for the best research paper, and he's got multiple publications, and he's currently professor and head Department of Endocrinology at AJIMS, Mangalore. Next, we also have for moderation Dr. Sahana Shetty. She is professor and head Department of Endocrinology, KMC Manipal, and she's won multiple awards for work on the DEXA databases, DEXA vertebral fracture, and she has multiple publications and book chapters on diabetes and endocrine disorders. Over to Dr. Krishna Reddy to prove your case.
Dr. Krishna, you can screen share now.
Yeah. I'm sharing. Yeah, good evening to one and all. Today I'm going to present two cases, almost similar presentation. The first case is 30-year-old lady residing in Qatar. She complains of neck swelling since 8 months. She has noticed a small swelling on the right side of her neck from the past 8 months, which was noted incidentally. Upon palpation of swelling, it was found to be hard. She also noticed another midline swelling, which she noticed at the age of 23, and she has been assured and told to have normal thyroid hormone profile. And she has been asymptomatic for a period of about 6 to 7 years, and she has not followed up. And now in Qatar, she was advised for ultrasound neck followed by FNAC. She is not associated with hoarseness of voice, any compressive symptoms such as dysphagia or dyspnea. No symptoms suggestive of hypothyroidism or hyperthyroidism. Her medical history is unremarkable with no history of head or neck irradiation, no family history of thyroid malignancy. On examination, pulse was 88 beats per minute, regular, and others were not remarkable, and except lymphadenopathy was noted at the level 2. Systemic examination was normal. Swelling was noted, the midline swelling anteriorly. And regarding swelling, it was initial swelling since 7 years, it was around 3 into 2 centimeters. Anterior midline, non-progressive, above the thyroid cartilage, not painful, moves with tongue protrusion and deglutition. And the recent swelling since 8 months, it was around 2 into 2 centimeters, right side of the neck. It was not painful, has not increased in size since its appearance. And it's hard in consistency, lymph node noted at the level 2. So on further investigation in Qatar, they had done ultrasound neck. It showed midline cystic lesion in the suprahyoid region, enlarged level 2 lymph nodes with cystic changes in the right side. Both lobes of the thyroid appears normal in size and shows normal echo structure with no focal lesions were noted at that time. On further evaluation, FNAC was done, showed finding suspicious of papillary thyroid carcinoma, which was arising in the thyroglossal cyst. So further investigation done at that point, it was normal. So background is summary. The 30-year-old lady residing in Qatar, she was presented with midline swelling of the neck, moves with tongue protrusion since the age of 23, and she noticed new onset swelling on the right side of the neck since 8 months, which it was not non-tender, non-progressive. On evaluation, ultrasound neck showed thyroglossal cyst and FNA suggestive of papillary carcinoma, which was arising from the cyst. So at this point, I would like to consider a differential diagnosis first as a thyroglossal cyst with the background imaging and FNAC. Probably it could be papillary carcinoma. And second, I would like to consider ectopic thyroid. And third, it could be due to enlarged lymph node. And further evaluation, MRI neck plane and contrast, it was done. It showed D2 weighted image sagittal section showed multiloculated midline cystic lesion with septations were noted. With the contrast T1 weighted T1 weighted image showing enhanced solid component in the sublingual region at the level of thyroid. It is suggestive of thyroglossal cyst. Lymphadenopathy was noted multiple lymph nodes, bilateral upper, mid cervical, and necrotic lymph nodes noted at the right mid cervical level. It suggestive of nodal metastasis. She underwent total thyroidectomy with bilateral neck lymph node dissection with cyst-trunk procedure, which is the gross image. Post-operative period, she developed hypocalcemia. She was managed with calcium infusion and oral supplements. She has been discharged with calcium citrate and active vitamin D twice a day. And further histopathological examination found to have a papillary thyroid carcinoma arising in the thyroglossal cyst. And the left lobe of thyroid shows micropapillary carcinoma with size of less than 1 centimeter. And the lymph node, one lymph node was involved out of 78 they examined, which showed metastasis without extravascular invasion. Pathological staging, PT1B and N1A. This was a thyroglossal cyst with papillary features. And the right side image showed micropapillary carcinoma with the papillary changes with the lymph node metastasis. Next, she underwent whole body scan after the HPE report, and they were administered with 100 millicurie of radioactive iodine. Followed that administration, they had done iodine 131 post-therapy scan. It showed no uptake in the anywhere in the body. So this was the first case. And, coming to the second case, she was 20-year lady, a student. She was residing in Mangalore. Complaints of neck swelling since 1 month. Anterior neck swelling present for 1 month prior to the presenting at the endocrine OPD. Which was swelling was insidious in onset, non-progressive in size, approximately 3 into 2 centimeters. Not painful, moves with trunk protrusion and deglutition. It was not associated with hoarseness of voice, compressive symptoms like dysphagia or dyspnea. No symptoms suggestive of hypothyroidism or hyperthyroidism. On examination, pulse were 80 beats per minute, regular, and lymphadenopathy was noted at level 2. Thyroid profile was done at that point, showed mild elevation of TSH was 6.4. Further, ultrasound neck was done. Thyroid showed elongated cystic lesion in the subglottic region, suggestive of thyroglossal cyst. And multiple hyperechoic areas in the both lobes of the thyroid with the thyroid spore lesion, and the left lobe of thyroid with enlarged cervical lymph nodes, query metastasis. So further evaluation, we had done USG guided FNA of the right cervical lymph node. It showed features. Cells showed overcrowding and overlapping with nuclear enlargement, with nuclear grooving and intranuclear inclusions with finely granular chromatin and moderate cytoplasm. So all these features are likely suggestive of metastatic papillary carcinoma. And further CT was done outside. It showed that there is a cystic lesion in the infrahyoid location, size possible of thyroglossal cyst, size around 2 into 2 centimeters. And there is a hypoenhancing nodule was there between the left lobe and the isthmus junction of the thyroid. So she underwent total thyroidectomy with the cyst-trunk procedure and central compartment and bilateral selective neck dissection from level 2 to level 5 under general anesthesia. Postoperatively, day 2, she developed symptomatic hypocalcemia and she was being managed with calcium infusion and calcium supplements. Histopathological examination features suggestive of papillary carcinoma thyroid with Hashimoto's thyroiditis in the right lobe, whereas the left lobe showed micropapillary changes, whereas the thyroglossal cyst has no carcinomatous changes noted. And the tumor characteristics of this malignancy was multifocal, with the size almost greatest dimension was 1 centimeter, with lymphatic invasion was not noted. And the regional lymph nodes examined, they told total lymph node examined was 20, left was 21, out of that involved was 1. In the central and right lymph node dissection or lymph node involvement 5 each. Coming to the histo HP, left side papillary carcinoma, right light lobe with the classic variant. Right side showed micropapillary carcinoma of the left lobe of thyroid with the lymph node metastasis. She underwent a whole body scan, and they had proceeded. Nuclear medicine team has administered with 100 millicurie of radioiodine therapy. Further, post iodine therapy scan, there is a mild mediastinal uptake was there, and after that they had done thyroglobulin level. It was less than 0.2 nanogram per ml, and she has not yet followed up till now. Done with them. Regarding the thyroglossal cyst, it develops from the persistent thyroglossal duct, which connects thyroid gland to the base of the tongue. The tract closes around 5th to 10th week of gestation of life. If failure of involution gives rise to the thyroglossal remnants. Thyroglossal remnants can present as a cyst, tract, fistula, or ectopic thyroid tissue. It is the most common congenital abnormality with a prevalence of about 7%. 70% of the neck masses diagnosed in childhood are thyroglossal cyst. In adults, it contribute to only 7%. So the median age of presentation is in 3rd to 4th decade. It can present as a bimodal distribution also with the 1st decade, and it can present in the 4th to 5th decade also. It is more common in women than men. It can found anywhere between submental and suprasternal region. The most common presentation of this thyroglossal cyst is a painless midline neck mass without compressive symptoms. The malignancy risk, it accounts for about 1% of thyroglossal cyst. Commonest among malignancy was papillary carcinoma, occurs in about 80% of the cases. And squamous cell carcinoma arising within the thyroglossal cyst is accounts less than 5%. Coming to Windstrom criteria, to say it is carcinoma arising from the thyroglossal cyst, yes, it should be fulfill that Windstrom criteria. So origin should be from the wall of the thyroglossal remnant. Lymph node metastasis should be excluded by histological examination, or primary thyroid malignancy must be absent. That if all these criteria, if it fulfills, then the primary carcinoma that is arising from the thyroglossal cyst. Coming to the diagnosis is mainly by FNAC, but FNAC has a false negative rate of about 47%. It is attributed due to the cystic fluid, so leading to the hypocellularity and resulting in inaccurate diagnosis. So this was the study done in Italy. It is a single center retrospective study. They had included 26 patients with differentiated thyroid carcinoma in thyroglossal cyst. So all have underwent cyst dissection and total thyroidectomy. So they had found out a concomitant papillary thyroid carcinoma in the thyroid gland was found in about 61%, and multifocal was seen about in 50% of the cases. So this concomitant cancer in thyroid and lymph node metastasis is present in the most of the cases. So coming to the management, in low risk cases, age is less than 45, cyst size less than 4 centimeters with no extracapsular infiltration or no neck node involvement. Cyst strength procedure is a choice, and with regular follow-up. Cyst strength technique is complete excision of the cyst and the thyroglossal duct with the central hyoidectomy and base of the tongue also removed. In high risk cases, if age more than 45 years, male, and cyst size more than 4 centimeters, with extracapsular invasion with positive lymph nodes and history of radiation, and their cyst trunk surgery with total thyroidectomy is the choice. And in such cases, post-operative radioiodine ablation is considered to suppression should be radioiodine ablation suppression should be considered. Thank you.
Thank you, Dr. Krishna Reddy. So any questions? We can't see any questions in the chat box as of now. Are there any questions, Pramila or Gani?
As of now, no, sir. No questions.
Okay. So I would like to ask Krishna. Why do the thyroglossal duct cyst develop? Because thyroglossal duct remnant will be there in almost all, but why only few people will develop thyroglossal duct cyst? That too at varying ages.
But maybe because of infection or inflammation that can cause blockage of the lymphatics or inflammation of the lymphatics that cause lymphatic drainage will be obstructed. But that can cause cyst increase in the size of the cyst formation of, and there is a formation of debris inside the cyst that can also form.
Okay. Okay. So there is one question in the chat box. In the two cases, one CT scan was done, another MRI. Which radiological imaging is better in thyroid and related structures? I usually go for CT, and I feel CT is better in thyroid and related structures. But MRI, I think the first patient was done outside, and she came to our department later. So, any other opinion?
It's the same for surgeons, especially it's a CT that we prefer because it's easier for us to understand and plan the procedure also. So I think CB go for CT scan.
So I would like to ask the whole panel, like in thyroglossal cyst, since FNAC is not very much reliable, we can't say that we can't rule out because the sensitivity for detecting malignancy is less. So is there a way like we can just observe and see whether the cyst is increasing in size or with serial ultrasound without doing surgery when we are seeing thyroglossal cyst for the first time?
I think what I saw, this is Dr. Hannah here, I think with the literature what I understood is that if there are any suspicious features on imaging, especially the commonest initial modality will be ultrasound or CT, if you see a solid mass or you see calcification, and then you go ahead and then do an FNAC, and if your imaging findings are still suggestive of say suspicious or malignancy, then another important thing it is to be done is to actually image the thyroid, because it's a multifocal tumor, and the concurrent thyroid malignancy, the risk is around 25 to 50%. So that's important, because once you know that thyroid is also probably involved, then the surgical management of thyroid cyst, what is recommended, of course, I think the surgeons will be in a better place to answer that. But what I read from literature is that in addition to the cystectomy, then you also have to do a total thyroidectomy, and then of course if there are any lymph nodes, lateral dissections. So the importance is to screen the thyroid thoroughly, and then again see if the patient also, and in such cases maybe you'll have to go for surgery. Again, I think one more thing we have to point out here is that although we saw 2 cases of thyroglossal cyst malignancies, thyroglossal cyst is a very common developmental abnormality of thyroid. The risk of malignancy is only 1%. So it is more of high index of clinical suspicion and screening, and of course in suspicious cases to operate. And also if you look at the literature, around 60% it was a post-op diagnosis where the histopathology said that it was thyroglossal cyst malignancy, I mean a PTC commonly what was seen, than a pre-op diagnosis.
Krishna Sheshadri wants to make a point. Sir, please. So, no. So, I one more point is thyroglossal cyst ductal carcinoma. And, yeah, sir. You're audible now.
See, 2 points. One is, did you have any tumor markers looked into the pathology? This is an important issue because very unlikely that this is a tumor that is primarily rising from the thyroglossal cyst.
No, sir. In these two, both the cases, it was not arising from thyroglossal cyst. There were actually one case, there was thyroglosal cyst carcinoma along with the carcinomatous focus in the thyroid.
And probably just papillary features and not necessarily a CA, right? Just having papillary features on a biopsy or because it arises from the wall, you should really show all the features of a papillary CA to call it, a thyroglossal cyst papillary CA. I think in both these conditions, both these cases is not probably papillary CA arising out of thyroglossal cyst. This is the one bit. The second
Yeah.
thing is, and what is concerning, was there a central node dissection done in the first patient?
Yes, sir. Central node dissection was done.
In
Yes,
the
sir.
first patient also?
Yes, sir.
Done,
Yes,
sir.
yes, sir.
And that was also, were the central nodes positive? No.
No, only one node was positive
Only
in the first patient, actually. Only one node. Krishna Reddy, which compartment it was positive? The first patient?
Central compartment, sir. Central compartment lymph node was positive.
So see, what, so this is the clue actually, because you are probably dealing with a BRAF V60 mutation leading to, or a high protein mutation that is happening, that is leading to cancer with a multifocal focus, right? And not necessarily the thyroglossal cyst is a red herring, correct? So there are two things. One is this may be an aggressive lesion. What I'm more concerned about is that despite the presence of mediastinal Mets, the thyroglobulin levels are low. So what are we dealing with? I mean, I would definitely look at the tumor markers in the pathology. The third question I have is, why are you using? Is there a reason why you're using a very high dose of I-131 post this thing? Can you get away with a lower dose? Because I think there is enough sufficient amount of data to suggest that you don't need to give 100 MCI at right at the beginning after thyroidectomy, unless
Yes,
you're thinking of a tumor burden, a very high tumor burden.
yes, sir. The first point, sir, actually, we don't have such now here tumor markers here, so it's a little difficult thing to do here. And since we are also not telling that it's a thyroglossal cyst carcinoma, it is arise from the thyroid gland only. Only things, if there is thyroglossal cyst, so how to make sure that only the carcinoma is arising only from the thyroglossal cyst, and whether all cases we are supposed to do thyroidectomy. That was the first point. And second thing, iodine-131 therapy, the dose was decided by the nuclear medicine physicians, not by us, actually.
One is it is so rare, right? That the thyroglossal cyst lesion should the thyroglossal cyst should not be considered as the focus of malignancy. Second, I would not take away any thyroglossal cyst that I see unless I see infection, or if I see that it is causing problems for the person. Third, here, because of the lymph nodes, the lymph node would have been my first target, even for the looking at the FNAC, because it'll give us because the third thing is that more than the CT or the MRI, the endocrinologist friend is the ultrasound, because looking at lack of hilum, lack of others are probably more useful. And in fact, when Krishna Reddy presented it, I was my mind was thinking that how come that he was not talking about the thyroid score of the ultrasound. But it's sort of important for us to realize that that all thyroglossal cysts don't. I mean, this is an exceptionally rare condition, and already this is a metastatic lesion. And one of the focus of the metastasis was probably, if at all, it was at the thyroglossal wall. That's the way I would look at it.
Yes, sir. Actually, the FNAC was done from the lymph node only, sir. The second patient, the FNAC was from the lymph node only, and it showed the papillary carcinoma.
I think that is what is more concerning is the lack of thyroglobulin elevation with the I-131 thing. So that is where I think the next focus on this particular patient. I don't know if anybody else had thoughts, but this was my view. I'm sorry I asked too many questions, but it was very
That's
interesting.
actually, it's good, sir. Actually, the patient underwent surgery only last month. So she's had to come for follow-up, actually. So thyroglobulin was done by the nuclear medicine physician immediately after the iodine-131 scan. So we are planning to repeat it after 3 months, and if required, then we'll go for further imaging.
Fabulous case, sir. Thanks for allowing me to speak. Thank you.
Thank you, sir. Thank you, sir.
Thank you.
Yeah. If there are no further questions,
Sir, we have more questions. We have more questions. I'm putting on the chat. Actually, there are a lot of questions. Just pick what. Yeah.
It's already
we can take
8:25. Shall we go ahead?
Quick questions, because we have exceeded our time. So
Yeah.
you can take quick questions. Yeah, you can just take quick questions and just quick answers we can give.
So there's a question which states that there was a patient with thyroglossal cyst PTC which was managed in a similar way. There was also a lymph node thyroid cancer on excision biopsy, but the total thyroidectomy specimen didn't show any primary malignancy. So your thoughts on this?
One minute, I missed that. I was just looking for the, the chat box only. So,
Yes, sir. It was a thyroglossal duct cyst PTC, which was also managed in a similar way with lymph node thyroid cancer on excision biopsy. But finally, the thyroidectomy specimen didn't show any primary malignancy, sir.
probably the FNAC was falsely showing some papillary, as Dr. Krishna Reddy was mentioning, that because of the papillary features, it was misdiagnosed as malignancy. Later, it turned out to be benign in the histopathology. So I think there are all are complimenting Krishna Reddy for his excellent presentation. I think I can hand over to Pramila. Ganvi, you can take over.
Ranvi, what I can suggest is that the experts can actually continue to type the answers in the chat box for the people who have asked questions.
Yes,
That
sir.
will also be useful. Huh?
Yes, sir.
Sure, we'll do that.
While you can move on, just type
Yes,
the
sir.
answers in the chat.
Sure, sir. I thank Dr. Krishna for presenting such an engaging and informative case. Special thanks to Ganesh sir and Sahana madam and also Krishna Sheshadri sir for moderating the discussion so effectively. Now it is my pleasure to invite Dr. Roma Pradhan madam to introduce our speaker for the next session, Dr. Amit Agarwal sir. Over to Roma, ma'am.
A very good evening to all. A very interesting case of thyroglossal cyst. And now we'll come to the retrosternal goiters. I'm sure they're really difficult to manage by the endocrinologist because they are like in confusion whether to send to a surgeon or not. And for us as surgeon, definitely it's a difficult procedure when it's retrosternal goiter. So whether it should be, whether asymptomatic retrosternal goiter be referred for surgery, it cannot be like better explained or better informed to us than Professor Amit Agarwal sir. I would like to introduce him. He is former head of Department of Endocrinology from SGPGI, currently working as Director, Endocrine and Breast Surgery at Medanta Hospital, Lucknow. And he's the past president of Indian Thyroid Society as well, and also of International Society of Oncoplastic Endocrine Surgeons. And there are many more achievements which I cannot elaborate right now. So, sir, over to you.
Yeah. Thank you, Roma, for those kind words of introduction. And I'm thankful to the leadership of ITS for giving me this opportunity to speak to you and share with you some of my thoughts about this topic. I believe I'm the opening batsman of this year's of Thyroid Clinic. So it's a particular honor for me. So I thought of taking up this topic because these endocrinologists are the first person to, see these patients, and it's always a dilemma whether to refer these patients for surgery, whether they require surgery or not. Let me first.
So kindly unmute yourself.
Amit sir, you can,
yourself.
sir. Yeah.
Yeah. So was I muted since the beginning?
No, sir. For a brief minute.
Audible. Very much audible.
Right.
Yeah.
So as surgeons like to define those goiters have a lower pole lying below the thoracic inlet as the retrosternal goiters, or at least 50% of the thyroid mass is below the inlet. So those are defined as sorry. Then those goiters whose lower border radiographically reaches the transverse process of the T4 vertebrae is also defined as retrosternal goiters. But the major component being intrathoracic meets the definition of a retrosternal goiters. For example, this is a case with a small part lying below the retrosternally. Then these are the examples of goiter which have a large portion lying below the thoracic inlet. But I'd like to define retrosternal goiters with a more practical approach, because those goiters which lie above the aortic arch they can be approached cervically. Whereas those that lie between the aortic arch and pericardium will need a manubriotomy, or where you just open up the manubrium. But those goiters which are well below the right atrium would require a full stenotomy. So this is a more practical classification for surgeons. Now, it's important to realize that almost 40% of goiters may be, retrosternal goiters may be asymptomatic, and they're incidentally discovered on the plain X-rays. And that is why I took up this topic, because a lot of endocrinologists might be seeing these patients where an X-ray reveals a retrosternal goiter, and they do not have any palpable cervical goiter. Now, but it's interesting to note that these patients may be having respiratory symptoms, which may range from mild to severe. Patient may give a history of isolated dyspnea, or in fact, they may give you a history of suffocation and choking at times. Now, this is very important to elicit this kind of history. Or the patient may give a history that the dyspnea or cough is worsened by some positions, either lying flat or rolling on one side. And this is very important to realize that these symptoms may mimic bronchial asthma. So patients may be passed off as having bronchial asthma, whereas actually the patient may be having symptoms resulting from a undiagnosed retrosternal goiter. Now, patients may also sometimes give history of hoarseness because the retrosternal portion may be stretching the recurrent laryngeal nerve, and that is why a change in voice may be experienced by the patient or the family members. Now, you can, in an asymptomatic retrosternal goiter, you can elicit or know whether the patient have a retrosternal goiter by doing a Pemberton sign or Pemberton's maneuver, where the patient is asked to raise his arms above his head. And as you can see in the frame on the right side, there is a suffusion of the face. Face becomes red. Patient may face difficulty in breathing, and there may be engorgement of the veins in the neck and the upper chest. So this is a positive Pemberton sign, and it indicates that the patient is having a retrosternal component of the goiter. For example, this man, the cervical portion was not so big, but he was having a large retrosternal. You can also elicit what is known as a Maranden sign, and where again the patient is asked, for example, this patient, she was asked to raise the arms above the head, and you can see the both sides external jugular veins were engorged. This again is an indication that the patient has a retrosternal component. So this is what is known as a Maranden sign. In our series from my previous workplace in SGPGI, we had almost 40% of patients which were asymptomatic, both in the malignant and the benign category. But what is more important is that a fair number of patients, almost around 12 to 13%, presented with frank stridor. And this is what is so important for these patients not to go or progress to this stage of stridor. I'll just take a case scenario. I saw a 61-year-old woman who had initially presented in the OPD for asymptomatic nodular goiter. And on physical examination, she had a multinodular goiter with tracheal deviation. Patient was advised to undergo surgery, but because the goiter was neither symptomatic nor cosmetically deforming, she refused. But because of the concern for the possibility of airway obstruction, surgical intervention was repeatedly advised, but the patient declined. Now, then the patient presented in the emergency with a severe respiratory stridor, and soft tissue radiograph of the neck and CT confirmed the presence of marked tracheal compromise. And so this was the goiter and with a large retrosternal extension, and this was the retrosternal extension you could see. Now, the patient was then immediately admitted and intubated, and a total thyroidectomy was performed, though histopathology was a benign multinodular goiter. Now, she was completely relieved of her symptoms, and there was no recurrence of goiter. On subsequent direct questioning, the patient admitted that she had experienced exertional dyspnea, which was intermittent, and also choking sensations, especially when she was lying flat. But since these symptoms were transient, she just passed it off, and she was well tolerated until this acute episode occurs, which sort of precipitated her present admission. So you can see she had those subtle signs and symptoms which were being overlooked by the patient, and she landed up in the casualty with an emergency situation requiring an emergency thyroidectomy. Now, the substernal goiters typically grow very slowly, and therefore the symptoms generally are not apparent, unless, of course, the goiter starts compressing the airway. And so most substernal goiters are identified during the 5th or 6th decade of life. But as surgeons, we like to put some indications of surgery in retrosternal goiter, such as a long-standing multinodular goiter, as was in this case, elderly patients with thyrotoxicosis, if there's suspicion of malignancy. But most important is that the patient has some sort of tracheal compression, especially if there's a 50% tracheal compression, which may be asymptomatic, but at any point of time, it can become catastrophic, as happened in our patients. So whenever you find a radiographic signs of tracheal deviation, which may be seen in as many as 1/3 of patients in some series, that's an indication for surgery, because even though there is no overt obstruction, it may lead to catastrophic compression. Now, let me touch upon the rationale for operating on asymptomatic retrosternal goiter, and I put forward some of the suggestions why we should be operating or referring these patients for surgery. The first indication is, or rationale is, that subtle symptoms are always present. As I mentioned in previous slides, if you take retrospective history, almost 1/3 of patients will admit that they had some sort of symptoms like a simple cough or a noisy breathing or symptoms mimicking bronchial asthma. So that indicates that the patient doesn't have overt obstruction, but may land up in catastrophic obstruction at some point of time. So subtle symptoms are always present. It's actually never really asymptomatic. So tracheal occlusion is ominous, as I already mentioned, and one must not overlook this fact. In one of the series, 5% of the patients landed up in emergency with impending airway obstruction requiring emergency surgery. The second rationale is a delay in diagnosis or treatment changes the grading of the retrosternal mass. So let me tell you, grade 1 is those goiters which extend near to the arch of aorta, and as I mentioned, these can be operated and retrieved from the neck only. Whereas grade 2 are goiters which extend beyond the arch of aorta, and they require some sort of sternotomy, either a manubriotomy or a partial or a total sternotomy. Now, if you allow or the time to pass, a grade 1 retrosternal goiter will change into grade 2. So a patient who would have been managed just by a cervical delivery with a very good outcome now changes to grade 2, requiring some sort of sternotomy, the results of which are not very good, because patients has to have an ICU care, and the rate of complications, the parathyroid injury, the nerve injury, and infections, bleeding, all these are very common after sternotomy as compared to the cervical approach. So a delay in diagnosis will change the grade of the retrosternal mass. So that's very important to remember. The third rationale is that the postoperative morbidity is more common in patients undergoing substernal goiter resection, especially with a sternotomy. And so morbidity is very high in the form of recurrent nerve injury or hypoparathyroidism, especially in the hands of occasional thyroid surgeons, and some sort of airway complications such as neck hematoma. And since they are all elderly patients, they require some sort of ICU care and may result in prolonged intubation with this attendant problems of airways. So a study by Shen et al. Found that the airway issues after thyroidectomy were more common in older patients with larger goiters, and of course, those with tracheal compression on preoperative imaging. And in this series, airway complications were seen in 7 patients who underwent a retrosternal excision as compared to those patients who did not have a retrosternal component. So the fourth rationale is that long-standing goiter is a risk factor for sternal split. So as I mentioned, the grade of the goiter will change and the patient will land up with a sternal split with its morbidity. And especially if there is a history of goiter with retrosternal extension beyond 160 months. In one series, they looked at the time frame and they said that if the goiter is more than 160 months old, there are more chances that a sternal split will be required. Second, if there's a lot of calcification seen on the CT scan with very high density, this again is an indication that a sternal split will be required. Of course, a posterior location is an absolute indication for a sternal split and a patient with a subcarinal extension. So these are the situations where the patients may land up with a sternal split if the patient is not operated in time. The last rationale is there is no other convincing treatment. People have tried thyroid suppression and radioiodine therapy and radioactive therapy, but these are not convincing treatments at all. So the only convincing treatment is surgery. So why delay when we know that there is no meaningful or effective alternative therapy for these retrosternal goiter patients? I'll just quickly touch upon whether we can predict which patients will require a sternotomy. It's important to remember it's not just the size, but the shape is very important. Most of the retrosternal goiters are icebergs. You know, what you see is just the tip of the iceberg, and what you don't see and which lies behind the sternum is a large goiter. This cannot be delivered from the neck. Or if the shape is an hourglass or even a dumbbell shape, these again cannot be delivered from the neck. And of course, if there is a discontinuous gland, retrosternal portion and the cervical portion, will have to do either thoracotomy or a sternotomy. Again, a very important feature which I touched briefly was knowing the tissue density. And if on the CT scan, if you find that there's a lot of calcification, then even though the retrosternal portion may be small, it's an indication for sternotomy. So thyroid tissue density in one of the series was defined as the strongest predictive factor for requirement of sternotomy. So it's very important to obtain a preoperative CT scan in all these patients to know the shape, the lower extent, and the density, which will decide whether the goiter can be delivered from the neck or the patient will require a sternotomy, either a partial or a modified sternotomy. So, ladies and gentlemen, the asymptomatic retrosternal goiter is a diagnostic as well as an operative dilemma. There is no reliable non-operative treatment available, neither thyroid suppression nor radioiodine or even radiotherapy, to prevent an enlarging goiter causing acute airway compression. So it should be treated with early surgery, rather than having it run the risk of acute airway distress, patient landing up in emergency, requiring a emergency thyroidectomy, because the outcome may not be as good as in a patient where you go for an elective surgery. So early surgery not only results in improvement of symptoms, and symptoms are always there, they may be subtle, but some sort of airway symptoms will be there. Early surgery will avoid sternotomy, and it will avoid all the attendant morbidity that comes with sternotomy in the form of prolonged ICU care, prolonged intubation, and other airway issues, especially all of these are elderly patients. So I thought I'll just share this topic where the endocrinologist on finding an asymptomatic retrosternal goiter may not go into a dilemma, but send the patient for early surgery so that the outcome is good for their patients. And of course, a good retrospective history is very important because some sort of airway symptoms are always present in these patients. So thank you once again for giving me this opportunity to interact with you. Thank you.
Thank you so much, sir, for this informative talk. And it's always a pleasure to listen to your talks. Can I ask from my endocrinology colleagues, like, what are your criteria to send these patients to a surgeon? Sir has already given many reasons to send them to us. So what are your criteria? Do you have, or you send all retrosternal goiters to surgeons?
So if they have compressive symptoms, then definitely we send, and most of them, as he rightly pointed out, will have. So once we take the history and we do a proper examination, see the Pembertons and other things, we normally get the things that they already have compressive symptoms. So I think most of the times we do send such patients for surgery, most of the times. I don't think that if it's a retrosternal, we actually wait. And I agree that there are so many factors, but compressive symptoms, as he said, that if you ask the history analysis properly and see, it will definitely be there. And most of these patients will complain of things. Because if we don't, then over a period of time, they may come. We had instances where patients, in spite of being advised for surgery, didn't go for it. And they did come with problems later where not exactly emergency or stridor, I would say, but they had to be taken up for urgent surgery. So I think it's the right thing to operate these patients on time.
Any more thoughts or?
How many questions are there?
No, ma'am, not yet.
I think one question from Dr. Shishadri: what is the incidence of malignancy in retrosternal extension? Is there any data? So I think it's a good question. The rate of malignancy is around 10%, but now the data shows that the rate of malignancy is the same as a non-retrosternal extension. So same in multinodular goiter as well as retrosternal extension. But it brings the point for surgeons that the retrosternal portion has to be delivered in toto, and it cannot be morcellated because there is always a risk of malignancy in these patients.
One of the question is there. Most of the retrosternal goiters are primarily those which starts in the neck and goes retrosternal. This is a question from the audience. This is primarily due to keeping MNG on follow-up in spite or knowing that at some point of time a surgery is needed. What is your outlook on this?
Yeah, so rightly said, because long-standing multinodular goiter, because of a negative thoracic pressure, have a tendency to enlarge that, and that is the pathway of least resistance. So they will have some sort of retrosternal extension. And as I mentioned, the more time passes, it will become from grade 1 to grade 2. So the goiter that could have been delivered from the neck now would require a sternal split with its morbidity.
But is the complication rate much higher with these surgeries? Because like not in with experts like you, but the thing is like many of these patients may not get the proper expertise. So then what is the complication rate? Because it is definitely, I think it will be higher.
Yeah, it's
Much
higher.
higher.
You have more hypoparathyroidism. You have more nerve
Yeah.
injury because the nerve is displayed. It's not in their
That is a major
anatomical
problem,
position.
yeah.
So nerve injury is very, very common, especially in non-expert hands. And then most thyroid surgeons may not be trained in sternotomy, and then you need a colleague or cardiothoracic person to do a sternotomy for you if you have not planned it beforehand. So definitely complication rate is higher. You would not want your patients to go into retrosternal, and that to grade 2.
So these actually retrosternals are very, these are surgically little challenging cases for the surgeons also. So definitely a proper reference at a proper time is important so that we can manage them well. That is all. Any more comments?
Do all cases of retrosternal goiter, when we suspect, we should ask for a CT scan, sir?
Yes, definitely. CT scan is the investigation of choice because it gives you a roadmap. It tells you what is the lower extent, whether you can deliver it from the neck or not. It tells you the density, tells you the size. So CT scan is absolutely important.
Since there are no more further questions, can we go ahead with the next session, ma'am?
Sure. Thank you.
Yes, sir. Thank you, sir. Thank you. Thank you, sir, for bringing clarity to such a controversial and critical topic. Definitely, your insights are will leave all of us too much to ponder about. So, and now moving on to the much awaited session, that is the quiz. Quiz has always been a highlight of the Thyroid Clinic sessions, and as we know, many of our postgraduate students are also quite excited to participate in this. So, before we begin, let's quickly review the quiz rules. As you can see, to participate in the quiz, it is we have to click on the button, that attend quiz button given on the screen, which is being live streamed. It is being conducted through a platform called as Slido. You're requested to use a laptop for the ease of experience. The quiz will run for about 5 minutes, and the quiz master will display the case or the description by screen sharing a PowerPoint file. There will be about 10 questions. Each question will be available for about 20 seconds with the timer on. Kindly do not refresh the page or go back to the previous page. So now I invite Dr. Vijay sir to introduce Dr. Neelakshi madam, who is our quiz master, who will guide us through the questions and answers. So over to Vijay sir.
Thank you, Dr. Ganavi. I think we have an interesting quiz, and the quiz master will be Dr. Neelakshi Deka, who is consultant endocrinologist at Apollo Hospitals and Dispur Polyclinic, Guwahati. And she's been a great academician, and she's been a best graduate at Dibrugarh University in 2002 2, and she's also won the A.V. Gandhi Award for the best thesis topic in endocrinology. She's prepared an interesting quiz with a lot of good questions. I hand over to Dr. Nilakshi Dekar to conduct the quiz.
Thank you so much, Vijay, sir. So we begin with the quiz, and that is one of the most exciting part of this scientific session today. I'll share the slides from my end. So should I be sharing the questions now?
Yes, ma'am. After reading out each question, ma'am, we'll stay like 20 seconds and then that's about it. Yeah.
Okay. So do we begin?
Yes, ma'am. Go ahead, ma'am.
So the first question is, which of the following does not aggravate Graves' ophthalmopathy? Smoking. Option B, radioactive iodine. Option C, thyroidectomy.
I'll give you the cue, ma'am, when to go on to the next question. We can go on to the next question.
The second question is, which of the following thyroid antibodies has been found to be related to poor pregnancy outcomes? Option A, anti-thyroglobulin antibody. Option B, anti-TPO antibody. Option C, TSH receptor antibody.
Ma'am, next question.
The third question is, following treatment of thyroid cancers, there are certain blood tests and imaging techniques which are done at regular intervals to look for recurrence. We just went through that in the previous discussions. Which thyroid antibody is used for post-operative surveillance of thyroid cancers? Option A, anti-thyroglobulin antibody. Option B, anti-TPO antibody. Option C, TSH receptor antibody. Coming on to the fourth question, which of these imaging modalities have the highest diagnostic accuracy for thyroid malignancy? Option A, MRI neck. Option B, CT neck. Option C, ultrasound of neck. We heard Krishna Sheshadri sir set a clue. He was speaking about which of these modalities are best for diagnostic accuracy for thyroid malignancies. MRI, CT, or UAG. Going on to the next question.
Yes,
20 seconds. So the next question is on medullary thyroid cancer. Which of the following is wrong about medullary thyroid cancer? MTC arises from parafollicular C cells, which are of neuroendocrine origin. They do not respond to TSH nor produce thyroglobulin. Radioactive iodine uptake is useful for the diagnosis. The most specific and sensitive MTC marker is calcitonin. So out of these four options, you have to choose the wrong answer. If we are done, we can go to the next question.
Yes, ma'am, we can go.
Question 6. All are the causes of low uptake thyrotoxicosis except option A, subacute thyroiditis, option B, factitious thyrotoxicosis, option C, struma ovary, option D, Graves' disease. So you have to tell us which is not a cause of low uptake thyrotoxicosis. So going on to the next question, if we are done. Tech team, are we done with the 20
Yes,
seconds?
ma'am. Yes, ma'am.
So question 7 is about a 30-year-old non-pregnant, please mind, non-pregnant lady with newly diagnosed hypothyroidism with a TSH value of more than 100. What is the recommended starting dose of thyroxine in this particular patient? A, 1 microgram per kg per day, 1.3 microgram per kg per day. Option C, 1.6 microgram per kg per day. Or option D, 2 microgram per kg per day. So moving on to the next question.
Yes, ma'am. You can go ahead.
Now, we know what is in news as regards MASLD nowadays. Now, a thyroid hormone receptor beta agonist recently received accelerated approval for the treatment of MASH or metabolic dysfunction associated steatohepatitis. Which of the following is that thyroid hormone receptor beta agonist? Option A, eproterone. Option B, resmetirom. Option C, sobeterone. Option D, triac. So thyroid hormone receptor beta agonist recently receiving approval for MASLD.
We can move on, ma'am.
So the 9th question is, now we are all aware that there are certain gene defects which occurs in congenital hypothyroidism. Can you name one particular gene defect in congenital hypothyroidism where both hypothyroidism and sensory neural deafness occur together? Option A, DUOX2 gene mutation. Option B, pendrin gene mutation. Option C, PAX8 gene mutation. Option D, PROP1 gene mutation. So which of these mutations lead to both hypothyroidism and sensory neural deafness together? So if we are done with question 9, we go to question 10.
Yes, ma'am.
Are we good to go? Yeah. So the final question of this quiz today is, according to the UGOGO clinical practice guideline, which of the following is recommended as the first line therapy for sight-threatening thyroid eye disease? Option A, oral glucocorticoids. Option B, high-dose IV glucocorticoids. Option C, immunotherapy. Or option C, orbital decompression surgery. Which of these is the recommended first-line therapy for sight-threatening thyroid eye disease? So I think time is over, tech team.
Yes, ma'am. We're finally done.
So now should we move on to the questions? Should I stop sharing the questions?
Yes, ma'am.
Yes, ma'am. If you can discuss the answers for the questions which were put up today and also the questions for the practitioners. So that will be good, ma'am. Yeah.
Okay. Vijay sir, you'll be doing the answers. Can we put up the G? So going on.
Okay, so I'll discuss the answers for today's quiz. So the first question was, we'll get the answers to the quiz shortly. We'll get the prize winners shortly. So the answers to the quiz will be, first question, which of the following do not aggravate Graves' ophthalmopathy? So the correct answer is thyroidectomy. So both smoking and radioactive iodine therapy have been shown to aggravate Graves' ophthalmopathy, whereas thyroidectomy does not aggravate Graves' ophthalmopathy. So the correct answer is thyroidectomy because it does not aggravate Graves' ophthalmopathy. Next question is, which of the following thyroid antibodies has been found to be related to poor pregnancy outcomes? So the correct answer is anti-TPO antibody. So studies have shown that patients with anti-TPO antibody have a higher rate of miscarriages. And even with assisted reproduction techniques therapy, anti-TPO antibody has shown to have worse outcomes. So the correct answer is anti-TPO antibodies has been related to have been associated with poor pregnancy outcomes. So next one is regarding thyroid cancers, which antibody is used commonly. So commonly used is anti-thyroglobulin antibody. This for follow-up, we do anti-TG antibody to assess the thyroglobulin level also. And anti-thyroglobulin antibody is used for follow-up these patients also. The correct answer is anti-thyroglobulin antibody. Another one is, which of these following modalities have the highest diagnostic accuracy for the thyroid malignancy? So the correct answer is ultrasound neck. So this is got by the thyroid staging, we can assess the exact diagnostic accuracy for thyroid malignancy. So commonly used is ultrasound neck. Which of the following is wrong about medullary thyroid cancer? So all of us know that this is the only thyroid cancer which arises from the non-follicular cells, which are called the parafollicular C cells. And they do not respond to TSH nor produce thyroglobulin. And that is why radioiodine is not useful for the diagnosis. So the wrong about this is radioiodine is useful for the diagnosis. It's not useful because they do not respond to TSH. And the calcitonin is the most sensitive marker. So answer is, which is wrong, is radioiodine uptake is useful for the diagnosis. So next one is all are causes of low uptake thyrotoxicosis except. So Graves' disease is a classical case of high uptake thyrotoxicosis. All the other mentioned conditions uptake is low. So non-pregnant lady with a high TSH value of more than 100. So normally we start away with a full dose of thyroxine therapy, and usually recommended is 1.6 microgram per kg per day. For pregnant ladies, we would start with 2 microgram per kg per day, but specifically we have mentioned non-pregnant ladies. So this is correct answer is 1.6 microgram per kg per day. So the latest update on this MASLD drug, which was recently approved, the TSH receptor beta agonist, correct answer is resmetirom. So gene defect commonly associated with both hypothyroidism and sensory neural deafness is Pendrin gene mutation. The syndrome is called Pendrin syndrome. So last question was, according to UGUGO clinical practice guideline, which of the following is recommended as the first-line therapy for sight-threatening thyroid eye disease? So the correct answer is high-dose IV glucocorticoids. That is the first-line therapy which is recommended for quick benefit, which needs to be done in these cases with sight-threatening Graves or sight-threatening thyroid eye disease. Sham, the leaderboard
Sir, we
is
can
come.
reveal the, you can stop the screen share, sir. We can reveal the winners on the screen share. Yeah.
Okay, just 1 minute. The medicine quiz questions.
I'll
these are
share the mine. I'll share the answers.
Yes, yes. So the medicine quiz question winners, I'll just announce. So the
Okay.
first prize goes to Mohammad Muzaffar Zargar. Congratulations. Second prize is to Dr. K. Raghavan, and third winner is Dr. Sudeep Kumar. Dr. Nilakshi, you will do the answers to the medicine quiz.
Yes, yes.
I'll just stop sharing the slides.
Sir, post medicine quiz answers, we can also reveal the winners for this quiz on the screen share, sir. Sir, should we reveal the quiz after, or we do it after this, sir?
After the answers.
We can just display the answers, and then at the end we display the winners for today's quiz, and then we close. Yeah.
Okay, ma'am.
Are my questions visible?
Yes, visible,
Yes.
visible.
So the GP, the medicine quiz is, which of the following is false regarding pregnancy and thyroid function? That there is a structural homology between HCG and TSH. That is option A. Option B, structural homology makes HCG mildly thyrotropic to be able to stimulate thyroid gland to secrete increased thyroid hormone from the beginning of pregnancy. There is option C is increased hepatic production of thyroid binding globulin, leading to raised total T4. And option 4, there is decreased urinary iodine excretion, leading to lower iodine requirement in pregnancy. And the false response out of these 4 answers is there is decreased urinary iodine excretion, leading to lower iodine requirement in pregnancy. So 3D is the correct, 1D is the correct answer. The question 2 was, conservative treatment of Graves' disease involves antithyroid drugs, and there are certain predictive factors for recurrence after antithyroid drug. Which of the following factors do not predict relapse? Now, there are certain factors which predict relapse in Graves' disease after antithyroid drugs. Now, which of the following options do not predict a relapse? Is it thyroid size? Option B, smoking. Option C, presence of severe Graves' orbitopathy. Option D, anti-TPO antibody. And option E, TSH receptor antibody. And the correct answer to this question, that is, which factor does not predict thyroid relapse, hyperthyroidism relapse after treatment with antithyroid drugs, is option D, anti-TPO antibody. The next question, although rare, a serious toxicity is associated with thionamides, which is an antithyroid drug. Which of the following is the serious toxicity? Option A, agranulocytosis. Option B, thrombotic thrombocytopenic purpura. Option C, myopathy. Or option D, torsade de point arrhythmia. And the correct answer is option A, agranulocytosis. In a patient with subclinical hypothyroidism, which of the following factors do not influence the decision to treat with levothyroxine? Option A, presence of goiter. Option B, anti-TPO antibody. Option C, pregnancy. Option D, lipid profile. Option E, age. And option F, presence of chronic calcific pancreatitis. Which of these do not influence our decision to treat a patient with subclinical hypothyroidism with levothyroxine? And the correct answer is option F, that is presence of chronic calcific pancreatitis. All of the others, that is goiter, presence of anti-TPO antibody, pregnancy, lipid profile, and the age of the individual influence the decision to treat with levothyroxine in a patient with subclinical hypothyroidism. Now, we know thyroid storm is an endocrine emergency, and which of the following is the wrong response in the treatment with thyroid storm? So which of these should not be used when we are treating a patient with thyroid storm? That is PTU, propylthiouracil, glucocorticoids, propanolol, inorganic iodide, or heating blankets. And the correct response is heating blankets should not be used. So in a patient who is having a thyroid storm, he will already be having hypothermia. And in these situations, cooling blankets are used rather than using heating blankets, which would be a wrong response. Now, going on to the next question, when initiating levothyroxine therapy to elderly patient with long-standing hypothyroidism, it is important to begin with a smaller dose and gradually up-titrate the dose. Now, which of these complications do we want to avoid by using a smaller dose in an elderly patient with chronic hypothyroidism? Is it option A, seizures? Is it option B, acute renal failure, which will result with a high dose of levothyroxine if initiated in an elderly patient? Option C, a flare of exophthalmos, or option D, overstimulation of the heart. And the correct answer is overstimulation of the heart. So this is to be avoided, and hence in an elderly, when we are starting with levothyroxine, we start with a smaller dose and gradually up titrate the dose depending upon the response of the individual. Now, this question is very interesting. A 62 years old female presents with recent complaints of fatigue, sleepiness, and weight gain, which are unusual for her. On evaluation, she gives a history of being diagnosed to have overt hypothyroidism. And she was diagnosed with arrhythmia around 5 weeks back. So 5 months back. So these symptoms of fatigue, sleepiness, and weight gain were because of hypothyroidism, which was diagnosed when she complained about these symptoms. And on evaluation on the history, she was diagnosed with arrhythmia around 5 months back and was taking an anti-arrhythmic drug. Which of the following agent is the most likely culprit in her case of causing hypothyroidism in a patient who has arrhythmia and is on an anti-arrhythmic drug? Which of these is the offender? Is it amiodarone, option A? Is it option B, lidocaine, option C, verapamil, option C, D, procainamide, or option E, sotalol? And the correct response is amiodarone. The final question is, a person with untreated hypothyroidism may also have low blood glucose, low blood pressure, high cholesterol, or option none of the above. And the correct response is a person who has hypothyroidism is also likely to have high cholesterol. So a person with hypothyroidism, so that is also one of the factors with which we treat patients with subclinical hypothyroidism. So if they have a dyslipidemia, then the need for levothyroxine in subclinical hypothyroidism could be explained. Now, the final question, I'm sorry, that was last but the final. And the final question is, which of the following drugs interfere with the intestinal absorption of levothyroxine? In a patient who is hypothyroid and is on levothyroxine therapy, which of these concomitant agents can impair the intestinal absorption of levothyroxine? Option A, calcium salts. Option B, bile acid sequestrants. Option C, iron salts. Option D, proton pump inhibitors. Or option E, all of the above. And the correct response is all of the above. In fact, in a patient with hypothyroidism, all of these calcium, bile acid sequestrant, iron salts, and proton pump inhibitors, all of these can impair levothyroxine absorption. Upper limit, the final question, the upper limit of TSH in early pregnancy suggested by the American Thyroid Association in absence of local population specific data is option A, 2.5, option B, TSH level of 3, option C, TSH level between 3 is 3.5, or option D, 4. And the correct answer in the first trimester or early pregnancy, the upper limit of TSH recommended by ATA is option A, that is 2.5, TSH of 2.5. And so that brings us to an end of the medicine quiz. And we've seen those answers, and I think we can go ahead with the results of.
Yes, ma'am. We are screen sharing the results, ma'am. 1 second. So these are the top 3, sir. Vijay sir. Yeah.
Yes. So I think the top 3, first winner is MM. I don't know the full form. We'll get the email address and contact the person. Congratulations to MM. And second is Ayush, and third is Rashma. Congratulations to the winners. I thank Dr. Nilakshi for having conducted the quiz. The medicine quiz was done before the event itself, and already I showed the winners. We'll be contacting the prize winners by email. And congratulations to the quiz winners for today. Over to Dr. Ganavi.
Yes, sir. The quiz discussion with Dr. Nilakshi Madam and Dr. Vijay sir definitely was truly insightful and enriching as well. So a big thanks for both of you for a detailed explanation and an engaging approach, sir. So as we come to the conclusion of today's session, I would like to invite Dr. Pramila Madam to share the closing remarks, ma'am.
Yeah, thanks, Dr. Ganvi. I think we had an excellent discussion, and this beginning of the thyroid clinics, we had an excellent discussion on the case, and we discussed about thyroglossal cyst, and we know that the cancer, though, is 1%. It is the commonest developmental anomaly of the thyroid, but we also understood that there are still a lot of things which are not clear and debatable. But ultrasound is one of the modality for thyroid which we should never forget, and that's the best modality. And also we did discuss about the dose of the radioiodine ablation post malignancy, which might be different at different centers, and that is also a topic of debate. So after that, we had an excellent talk by Dr. Amit Agarwal and moderated by Dr. Roma on the retrosternal goiter, and we know that that is one of the things which many a times we are not able to decide whether the patient needs urgent surgery or we need to wait. And then the quiz was definitely the thing which we always look forward to. All our students wait for this. And we had an excellent quiz for both the practitioners, physicians, as well as for the students, which we had today. And the answers have been told, and I think it will benefit the students as well as the practitioners and the general practitioners and the physicians. And Dr. Prashant Shadri is also there with us, and also Dr. Arun is there. So if they would like to comment anything before we close, and then Dr. Ganvi will tell us about the next thyroid clinic, which will be next month on the second Wednesday of every month. We are going to have this thyroid clinics from 8 to 9 p.m.
Thank you, Pramila. I don't know whether Krishna is there. Krishna, over to you.
No, I'm here. This is the IT's quiz team show. Fabulous start. Very close to Vijayadashmi, and I especially with so many women in our team, I'm very surprised that they were able to take this time off in Navratri and be part of this. Really grateful to all of you. Keep this going, and as a I'd like to sort of also acknowledge that this is the legacy of Dr. Sarita Bajaj, the ITS clinics, and we are continuing that legacy, and keep this going, and happy for all of you. And again, happy Navratri to all of you. God bless you.
Thank you, everyone. Thank you so much. Over to you.
Yes. So looking ahead, we are excited to announce the next Thyroid Clinic session, which will be on 13th of November. We hope everyone will join us again for another enriching experience. So since we have come to the end of the session, I would like to wish everyone a happy Navratri, and we'll be closing now. Thank you. Good night, everyone. Good night, madam. Yeah.
Thank you.
Good night, everyone.
Madam, thank you. Thank you, bye.
Thank you so much, ma'am. Thank you.
Okay, thanks, Sham.
Thank you, ma'am.
Good show. Yes, it succeeded.
Thanks, ma'am.
Thank you. Thank you.